Well, hello everyone, and welcome back to the medical equipment world and healthcare Get the Scoop, the podcast where we break down durable medical equipment, patient care, and real world solutions for caregivers, families, and healthcare professionals. I am your host, Tara, with CFS Medical Supplies and Equipment, CFS Solutions. And whether you're new to DME or a seasoned provider, this show is here to give you insight, tools, and stories that matter. And of course, we always read our disclaimer. The information shared in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult with your professional healthcare regarding any medical decisions or concerns. Neither the host nor guest assume liability for actions taken based on content discussed in this episode. And you guys always know I say in any other episodes. So hello and welcome. You know what? I am so excited. Diane, we have Miss Diane Carvo here today, you guys. She is back. And I am so excited because today we're going to be talking about something that I have been harassing her about, which is hospice. I'm like, you know what? I keep hearing, well, first of all, we get a lot of clients that come in or they'll call about a particular product that they've received that they weren't happy with. They want something more advanced. You know, they got some equipment, but their loved one was on hospice, but now they are no longer in hospice and the equipment is being picked up. I didn't like the hospice. I mean, all these things, we hear it all, right? And so I said, Diane, I want you to talk to the audience about hospice, the fraud that's going on in hospice, what families should look for with hospice, what questions to ask. Because let me tell you guys, I'm learning today too, because I have no clue. So I'm excited to ask Diane some questions and I'm excited to hear the answers. But for in the beginning now, what I'm going to do is go ahead and read Diane's her bio. Diane, welcome.
Hi, Tara. Thanks for having me. We're going to have a
Yes.
real hot topic here.
Yes, we do. Yes, we do. And I am because I feel for the families because they don't know or they don't know, if they want to make a decision or make a change, they're uncomfortable, unhappy about how do they go about doing that? What should they look for initially? All these questions. I have questions because I'm like, oh my God, like I feel so bad for them because they didn't know how to go about doing some of the things or whatever, and just kind of sharing information with as we do resources and information, Diane. So, welcome and thank you for taking out your busy time because I know Diane, you guys, has Caregiver Relief, a podcast, which is one of the top podcasts in healthcare for caregivers. And so I am excited when she take out her busy schedule to come and join us on the medical equipment world and the healthcare Get the Scoop. So thank you again, Diane.
Oh,
Okay.
Tara, I'm very grateful to be here.
Yes.
Um, and when you wanted to talk about hospice, I just want your listeners to know I've been around as a nurse for 54 years.
That's what I'm talking
So
about. Yes.
So when you said hospice, and I'll tell you when I'm hearing about the fraud and stuff,
Mm.
I had to do some research because it was very confusing to me, and I'll tell you why. I've worked in hospice, but
Uh-huh.
I've also been a nurse for a long time, and
Mm.
Medicare, the hospice benefit began in the 1980s.
Mm.
So it was just started, and it was a way to support terminally ill patients who
Uh-huh.
had less than 6 months or less to live. And I
Mhm.
want you to know that my father in the mid 80s, I had him put on hospice. And I will tell you, in those days, hospice was very, very different. My dad was told he had a pancreatic cancer after a massive surgery he had. And if you don't mind, I'm going to share a little personal story with
Oh,
you
of
about
course, of course.
if that's okay. My dad was told he had cancer and that he had less than 6 months to live. My dad was a letter carrier. He had a timeshare he purchased in Hawaii, and every other year for 6 weeks he would go.
Hmm.
And this was the year that this was in he was diagnosed in late November,
Hmm.
and in January, he was supposed to go to Hawaii for 6 weeks. And the first thing out of his mouth when the doctor tells him, his heart, you could just see his heart sink. And he says, I guess I can't go to Hawaii.
Mm.
Well, I'm a smart aleck. And, being a nurse, I was in my 30s at the time. And I just looked at my dad and I said, well, you're not dead yet. We'll just put you on hospice.
Oh, wow.
And,
Okay.
and my dad, oh my God, you know how people are about talking about death and dying. You just don't do
Hmm.
that.
Yeah.
Anyway, I said, if you're feeling well enough, um, I- we'll get you hospice set up over there as well, so that, if you die over there, is that going to be a problem for you? He goes, no. I said, that's
Mhm.
fine then.
Okay.
So he went over to on to I put he went to Hawaii, was there for 6 weeks. The first week he was there, he was doing so well. He came off of hospice.
Hmm.
And it was like he lived a really good life. He just enjoyed himself so much. The day before he was coming home to Pittsburgh, Pennsylvania, and it's a long trip, you guys, and he came home and we put him on hospice right away. And he died a few weeks later.
Mm.
But hospice then was different. It was there was a lot of volunteers. It was mostly run by non-for-profits. It was designed to be comfort care, nursing support. I think that one of the things that people don't know and understand is from the beginning, Medicare hospice was not designed to provide 24-hour care at home. It was only designed to supplement the family caregiver. And that means the family caregiver burden was already built into the model from the start.
Mm.
And this frustrates me because we're not prepared. The family caregivers aren't prepared. So it's all about dollars and cents. So let's talk about how this changed from being a system of a lot of not-for-profits to now in the 80s, late 80s, early 90s into the 20s, 2000s, hospices were closing left and right. And I didn't understand why. And then I learned that the inpatient hospices were closing, the not-for-profits were leaving. And it was because the reimbursement rate was so low in those days, it still is, for hospice that um, the companies couldn't survive.
Mm.
So move forward to today,
Uh-huh.
Medicare thought, oh, well, we've got to do something. Our government, oh God, we need less government, not more. But our government involvement said, oh, let's solve the problem. We'll give the providers, the vendors who provide the hospice services, a daily rate. And they can get a daily rate to make money. Well, that it set us up for terrible, terrible fraud. And that's what's happening.
Mm.
And one of the things you're going to learn is the bad actors learned about hospice, how it could be profitable if they enrolled people who were not truly terminal. They provided very few services and they targeted people using misleading marketing or signed up people who without clear understanding or consent. So we went from this beautiful service to a payment system that can underpay high quality, high touch hospice care, but can also reward low service, fraudulent hospice operators. Oh, we've got a big growth in for-profit hospices. In fact, I'm going to share with you that in California, in one building, there are 89 registered hospices uh, registered to that address. You've got,
89, Diane?
yes, 89. And get this, there are more hospices in a 2 or 3 uh, uh, block area than ever before. It's just incredible. Um, in
Wow.
fact, according to MedPAC, for-profit hospices accounted for about 82% of hospice providers in 2024. while hospital based and the hospitals hospices provided in skilled care
Mm-hmm.
declined dramatically. And it's really, really sad. And the problem with the hospice fraud is not just that it's stealing taxpayer dollars and our healthcare dollars, but it steals our trust and it's harming dying people and it's confusing families. And it's
Yeah.
also damaging the reputation of good hospice providers. The
Yeah.
other thing, of course, the government, they meant well, but everybody tells me the road to hell is paved with good intentions.
Yeah.
And while uh, they, thought this daily rate, so if the hospice gets paid whether your hospice provider shows up every day or not.
And that's really interesting you said that because I had a client actually a few days ago, and she was complaining to me about the hospice company that she was with didn't wasn't showing up. I think she said they came
Yep,
once and then she called them and she didn't hear from them, and I was like, well,
yep,
I don't know enough about it to even comment on it, you know?
yep,
And so I just said, well, maybe you should just call them and just kind of talk to the manager or the director and just kind of see what they say, you know?
yeah,
But I keep hearing all these different stories, about hospice. I was like, we need to talk about this. I need to just know, because I want to know. I don't even know. I
yeah.
want to know too.
Yes, yes, yes.
Oh,
And there are steps, and we can talk about that. I know we're
yeah.
going to talk about that later, but
Mhm.
I want to get into people understanding that right now there are hospice provides it the reimbursement is $200 a day, a little higher, maybe 250
Uh-huh.
a day to provide care.
Okay.
And they used to have a lot of volunteers come, to help visit, and the
Mhm.
chaplain and the social worker. I mean, there was somebody checking on the family. The nurse may come once a week or twice a week or more often. The higher acuity level, when you're really, really sick
Yeah.
and they need oxygen, they need suction, they
Yeah.
need a special bed. Those kinds of cases are the hospices lose money on. And
Well,
that's why they want people that aren't really sick or aren't going to require a lot of services. When my dad was on hospice, an aide came 3 times a week to help bathe him. And, initially he didn't have a bed they didn't bring a bed in until 2 days before he passed. We didn't need it then. He was able to still get up and do things.
mhm.
But when he went into a coma, we had a hospice bed brought in and we cared for him round the clock until he passed. So there's all kinds of people die differently.
Yeah.
And some people require a lot of medications. You don't want to give a lot of medications, but there's pain medications, there's medications to dry up secretions. You want to put chapstick on people and lotion their skin to make them feel comfortable and keep them from breaking down. So you want to make sure you treat their backs and bottoms and heels and elbows with lotion so that they don't break down. I mean, there's things you can do, and they do provide air mattresses and stuff.
Yeah.
That is not happening like it did before. It's just not happening.
Wow. I tell you, I know that there is a standard that they normally would bring in, right? So they do, I've seen them like they'll bring in beds and things like that because I've had some clients where they are on hospice and they have the bed that there's brought, which is technically the more of the basic bed that the insurance normally pays for. And the difference with the hospice bed is that it is a lot of times it is full electric, which is good. Now it still doesn't go high enough,
Yeah.
or low enough on things like that. But I mean, I guess some families who are okay with that, that's what they use, right? But I know
Yep.
we've had clients that they're like, well, I need something more advanced because I just need it's because they're doing a lot. They're suctioning their loved one. They're doing a lot. So they want something that's more that's the bed is higher, when they elevate all these things. So it's just a little bit that goes into it. So I do see that. But I mean, just understanding the dynamic of it. So you talk about an agency that sets up a hospice, right? And then they
Hmm.
bring in and they contract because I've had hospice companies to reach out to us to do some hospice and we won't do it because it's just not um there's a lot that goes into it. And so for us
Well, there is, and
it's
you know, the logistics are
yes,
really hard for
it is.
companies.
It
First
is.
of all, I find it really strange that a hospice company, if a patient already has a bed in the house because of the care they're receiving, and they go on hospice, they have to change out beds. To me, that's the stupidest thing I ever heard of. Because I'm telling you right now, these hospices are bringing in substandard equipment. I'm just gonna. You may not see it or say it, but I can because I've seen it, and it's very frustrating to me when they're not bringing in a comfortable bed. They're not bringing in. I mean, they are still trying to bring in the old crank beds. I didn't even know they still existed.
Yeah, it's rough. Well, the reason why they do the exchange is because I'll give you an example. Say
Yeah.
for us, if the patient is, we just forgot about your bio.
Oh, that's okay.
We'll get
I'm at caregiverrelief.com. Look me up.
there you are. Okay, then you can just go and check out her bio right there, you guys. She's often on here anyways, okay? But well, normally what happens, I'll explain that part.
Yeah,
So you have a patient who may be just an example on insurance and they may be on getting their equipment. They may have a bed in there on the home and now they're switching. So example for us. So we're a provider, we may provided the bed, we're billing insurance direct for it because of this is what they're on. Well, now the doctor has put the patient on hospice, maybe a different doctor for whatever reason, and then we're not contracted with that particular
gotcha.
hospice company. So that
Gotcha.
hospice company may have a contract with another supplier that may can get the equipment at a reasonable rate, whatever that rate is, a contract they
Yeah.
have. And then that's when we would have to go in and pull our bed out and then they would bring theirs in because the patient is in hospice now. Now for
Yes.
us, we don't do hospice, but what we because logistically it's not feasible for us. Now it doesn't say mean for someone else, but for us, we deal with a lot of innovative products. And so because
Yeah.
of that, a lot of the families who are on hospice, they call us in to bring in better beds. Now they
Yeah.
still remain on hospice, but they just want a better bed, right? So they may say, oh, I need a better bed, I need a better lower loss. I need you to bring that in, and they'll pay out of pocket for that
Yes.
because they
Yes.
want their
Yes.
loved one to be comfortable. They want the best product that can do all these
Yes.
different positionings and all that. The regular beds don't do that, so that's what
And
they bring those in for.
Tara, I think that when you're going actively dying, I will tell you right now, families don't know you're supposed to turn a patient every 2 hours, reposition them,
Mhm.
and to do skin care and to look for breakdown. And a comfortable bed with the right mattress and products can give a give somebody comfort, the patient a comfortable end of life experience.
Yeah.
I'm finding some of these beds, I mean, they're still bringing in the crank beds. They're not even putting on a low an air mattress on some of these beds,
Hmm.
or even a foam mattress for their
Hmm.
butt. And I'm like, it frustrates me. And they're not always providing the chucks and all the things that you need to
Hmm.
put under a person to keep them clean and dry. and comfortable. So, there are a lot of issues I have with some of these hospice companies. Now, that is the difference between a good hospice company and a an unsavory or one that is run by bad actors. The
Mm.
bad actors won't provide good beds. They don't want to provide all the tools like the air mattresses. They may be even skimpy on the amount of chucks they provide. I
Mm.
mean, there's a lot of things that go in to hospice. And one of the things hearing and seeing is how people that have a high need patients cost more.
Mhm.
And it's more profitable for somebody to take a patient in that has the bare minimum. And I think this is what comes into play is
Yeah.
family caregivers don't know what they don't know, Tara. They just
Yeah.
don't.
Yeah.
And they don't know that this bed can not only hurt them when they're turning and providing care, but it's hurting their loved one as they go through their death and dying process. Their skin's going to break down. It's hard to keep them clean. There's just a lot of things, and they're not getting the support they need at a time of when they really, really need it because I just did a podcast yesterday with a death doula, and a lot of hospices are not there talking you through what happens at the end of life.
Oh, wow.
Patients will call and say, "Oh my God, this breathing is going on. What do I do? What do I do?" And, in the olden days, I come from the dark ages, a nurse would come out and sit with you and explain and talk to you. They don't do that. In fact, a lot of them now don't want to send a nurse out until after the patient's died to for them to determine that the patient has died to sign the death certificate. And that's sad. So we really have a situation where families that need support, they deserve support. And that's why you and I are doing this because I want people to know you have rights.
Yeah, well, we're gonna get to it too. My gosh, like, oh my goodness, like, yeah. So I'm gonna ask you some questions, Diane, that I have. Yeah, because we
Okay.
want to know. Inquiring minds wants to
Okay.
know, and the thing
Yes,
of it is we want families to not feel like they're alone, and we don't want them because I'm telling you that I don't
absolutely.
even know what to do. Like, what should I call them? Is it okay? You think it's okay? All these things.
Yeah.
So yeah, so I'm gonna just jump right on in. So.
Okay.
Uh, and one of the questions, why is hospice such an important topic for family caregivers right now?
Well, you know what? First of all, we have a system
Mm-hmm.
where Medicare has changed the reimbursement rate for everything. We're moving to a cost sharing plan,
Mm-hmm.
and one of the things I'm seeing is um, I shouldn't say it this way. I'm going to say it in a more appropriate way.
Okay.
Um, Family caregivers are the largest pillar of the long-term care industry. They are unpaid, uneducated, and provide $1.1 trillion in unpaid care. And I'm going to just say shit rolls downhill. And I'm
Okay.
sorry, but you know what? The hospitals aren't doing the care, the therapists aren't providing the services needed because of the reimbursement. And everything is falling onto the lap of the family caregiver. So we are really at a really critical time. There's many things going on, and the next few years are going to be awful for us, and it's going to impact the future of healthcare. We really need healthcare reform because in the next 5 years, the end of the baby boomers, the youngest, are going to be retiring. The oldest are turning 80 soon.
Wow.
And so we're going to see death and dying a lot more, and we need support. With all the low birth rates, every generation since before the after the baby boomers has not replaced themselves in numbers in population. So we have a situation where we don't have enough youth to take care of our elderly, and every generation after us is going to deal with this because there's just not enough, and we also have more solo agers and childless couples than ever before. And that's going to impact us. We also are going to have we have a situation where our youth is our tax base and they're our workforce. So things are going to be costing more and more as we move into a system. And there's one other dynamic nobody else is talking about that's really going to dramatically impact healthcare is the baby boomer nurses, my age, are retiring in the next few years. And that's like one third of the nursing population in hospitals. And the young nurses, we do not have a shortage of nurses. We have a shortage of nurses who do not want to work in stressful situations that they're
Mhm.
placed in. They don't want to work there. The younger nurses are saying, "Hey, I'm interested in a quality of life. I'm getting beaten up by patients, and management blames everything on me." And one of the things that's frustrating, nurses don't make, I know people think, oh, they make great money. Yeah, yeah, yeah. Well, let me tell you, I'm in South Carolina. I have intensive care nurses that are only making 30 to 35 bucks an hour. And I came from Pennsylvania where nurses were making that kind of money. Bigger the cities like New York and maybe in California, you may make it, but your patient care ratio is so bad, it's unsustainable and it's unsafe.
Wow.
So we're in a public health crisis right now that
Mhm.
nobody's talking about. And hospice is such a beautiful thing, and it's meant to be to be comfort focused care for those with terminal illness, and it's generally provided
Mhm.
or ordered when a physician believes life expectancy is 6 months or less, and if the illness follows a normal course, and it can be provided at home where they prefer because it's cheaper.
Mhm.
But it can be provided in assisted living in a nursing facility or in some inpatient hospice settings or hospice homes. But those are going by the wayside because the reimbursement rate is so low that the facilities don't want that to provide that level of care.
So you're saying that the facilities themselves are going away, but the
Yes.
hospice, but people providing hospice services is not though.
Oh, that's
With
rampant right now. Like I said, because of all
yeah.
the fraud. Yeah.
Right, right,
Yeah.
right. Because they're getting $200 per day. So basically, you have a company that owns a hospice, and they
Yes.
have they're providing services in home for
Mhm.
families whose
Yes.
loved one is on hospice.
Yes.
And in doing so, that particular agency is charging $200 per day
Yeah.
for that patient, your loved one on hospice, and
Yes.
then that's how they do it. But they may not show up. They might show up. The equipment that you're getting, you might get it. You got, whatever you're getting,
Yep.
whatever it's comfortable, whatever all that is. But that's
Yes.
pretty much how it works. So let me
Yes.
ask you the next question. What is
Okay.
hospice supposed to provide when it's done correctly? So what should families be looking for? You're like, hey, loved ones on hospice, what should I be looking for?
Well, the hospice used to provide everything from a nurse going in to educate
Mm-hmm.
um, and assess once or twice a week, depending on the patient. They
Mm-hmm.
had services where an aide would go in and help bathe the patient
Mm-hmm.
maybe once, twice, or three times a week, depending on the level of care needed. There
Mm-hmm.
were social services. Social workers would go in and see if there were resources. They also would provide care to the family caregiver and give them, you know, talk with them and work with them in a lot of ways. Like a perfect example, when my dad was passing, my stepmother didn't even want me to change a Band-Aid on him. She didn't want me to help. She didn't want me, and it was really hard. She married my dad right after my mom died, and she just didn't care for me. I'm okay with that. But we were also never allowed to talk about my mom, and we had to act like she never existed. Well, a social worker came in and intervened because I asked for a consultation because I wanted to be able to provide a level of care that I knew my dad deserved, and she was not a healthcare provider. She knew nothing. So they intervened. But there also are chaplain services.
Hmm.
And there are chaplain services that to meet the spiritual needs of a client and the patient and the family, if that is something they want. And that's really important as well. And then I worked for one hospice that had music therapy, and they would send in people that played guitars or their portable organs or pianos
Hmm.
and entertain and provide comfort in that way. And it was just lovely. Um, Today's hospice is very different because it's hard um, provide those kinds of services. You have to pay for travel mileage. You have to pay for benefits for patient or the staff. You have to pay for so much that it's if you get a nurse once a week, I think that's a good thing. They need for medication support. I think the equipment is always is always going to be an issue now because the hospices really are struggling. And to have good equipment, you're better off to privately pay for out of pocket. And that's one thing our listeners have to know, Tara, is we are moving to Medicare has moved and is continuing to move to a cost sharing platform. So don't think that you're going to get away with, if you want good quality
Yeah.
care and good quality equipment and services, you're going to have to pay for it. There's going to be a growth in concierge nurse services, and there'll be a growth in PT services, all concierge doctors as well. We're already seeing that
Yeah.
because the reimbursement has changed so much.
Yeah. Well, I see that a lot. I see a lot
Yeah,
of concierge doctors, and PTs, wound therapy. I mean, you name it. It's across the board now to
yeah,
have concierge doctors, concierge services. And we kind of are like that concierge type of thing because we're more personable. We're not your traditional medical equipment company, if that makes sense.
right.
So, we
Yeah,
actually go physically into the home, analyze the situation. It's more personable. It's more of a concierge type of service. And that's what
yes.
families want. And they want that, that more of that consultative type of service where, you kind of cover everything that they pretty much need, if that makes sense. Because even for
Yeah,
us,
oh
we
yeah.
need resources for a lot of families too, like not just equipment, but I recommend like home health agencies and
Yes.
people I know, and oh, they call this guy, and that could be anywhere in the United States. Like because
Mhm.
that ecosystem that we have, like even for me and yourself, talking and communicating, and we've talked to so many different people, you kind of put these systems together and now you're able to recommend or hey, call this company, call this person, and
Yep.
get those done and stuff. So the next question, Diane, why do you say good hospice can be a gift but fraudulent hospice can be dangerous? Ooh,
Oh, that's a good question, and I have to tell you that good hospices struggle with bad actors. You have perfect examples right now of a good hospice cares about you. They're going to provide you with the best possible care they can, and they're willing to work with you. There's flexibility within them, and they show up. They have a schedule. They educate you. They support you. They provide you. One of the things that hospice also does is provide 18 months of bereavement services after for free.
Wow.
And and I can tell you that very few hospices even talk about having that. But I can also, so who are the bad actors? The bad actors in hospice are the ones, they're the ones that are having you sign up. They don't they, well, you had an example the other day you called me about one of your clients wanted to see the nurse's license, or
Yeah.
and the nurse wouldn't show her. And I'm like, oh my gosh, I've done home care, I've done hospice. You carry around your nurse's license with you all the time. It's just a little card. But, I can tell you that I have had family members, and I have no problems with this, that want to see my driver's license as well, and
Mhm.
take my driver's license information down. I don't have problems with that. Maybe some nurses do, but having the nurse showing a license, or at least, providing them with a copy or
Mhm.
whatever, shouldn't be an issue. But and there are steps that you can take, but the shoddy nursing companies, or the hospice companies, just aren't going to provide you with a lot of care. They're not going to show, like I said, they're going to show up, or they're going to send substandard uh, equipment, and you do have a right to refuse those things, and people don't understand that. And the other thing that uh, families don't understand is you can fire a hospice and have another one come in.
And
You
that's what I was
have
going to
that
get to
right.
too. Yeah.
And I have done that myself as a care manager.
Mhm.
I've had my clients call me and say, "Oh my God, this is awful." And I'm saying, "That's easy." I call them up and say, "You're out, get your stuff out of there, and we have another one come in." And you do have that right to
Now, what do
to
they have to do though? So, like your ancestor, you got one, and you want to get rid of that one, and you want to go to another one. How is it? How do you go about doing that?
Well, you first you would call the hospice company.
Hmm.
And here's the thing, there's what you have to deal with now, especially in California. Kaiser Permanente is, I think, your biggest managed care provider.
Hmm.
You have more managed care in that state for a longer period of time than the rest of us have had. So your situation is, first, in reality,
Hmm.
a managed care, or a social worker in a hospital should
Uh-huh.
provide you with three hospice companies they can refer you to.
Hmm.
That's really important. You should be able to have them come to your home, talk to you, and you interview them, and you go with the best company that fits right for you.
Hmm.
And we'll provide you with a list of questions and stuff that you can have at the end of this. We can do that. But
Okay.
the other thing is, you have, and the thing is, you can actually self-refer yourself to a hospice.
Mm.
People don't understand that as well.
How does that
It
work?
lets Well, let's say your family member is not feeling well, and they start talking about palliative care or hospice,
Mhm.
and you want to look around. You can actually contact different hospice companies. They can come in, meet you and evaluate you, and if they feel you're appropriate for their services at this time, they will call your doctor, your PCP, and ask for a hospice referral. So you can do self-referral. So if you have a hospice that you're not happy with,
Mhm.
again, if you're managed care, you've got to go through the Medicare or Medi-Cal system. You
Right.
have to go through your managed care company to see what companies are in your network.
Okay. When you have an advantage plan, pretty
When
much,
you have an
versus
Advantage
traditional
plan,
Medicare.
yes, or
Okay.
I know you have Medi-Cal, and that is another big thing is, they have to be willing to take your insurance, Medi-Cal, if that's your only insurance.
Right. Right.
And
Okay.
that's a tough one too. because
Yes.
nobody in reality, I will tell you right now that providers of services don't want to take Medicare Advantage, and they don't want to take Medi-Cal or Medicaid. They just don't want, because the reimbursement is so awful and they don't make much money. That's why they like the traditional Medicare with a supplement plan.
Yeah,
That's the reality of it.
it's true. That so we see a lot of that too. That is so true. What
Yep.
should families understand before they sign the hospice paperwork, Diane?
Well, I think that they really need to understand that
Hmm.
there are things that they can ask,
Hmm.
and